how to manage and how to tackle this difficult situation. To solve that difficult puzzle, IAP Kerala, in association with Unicef, conducting so many workshops regarding IAP, this COVID management in pediatrics all over the state. I think this year, this is our 9th or 10th CME of this kind. Once again, I welcome all of you to this webinar. And with these words, I invite our state IAP President, Dr. Vijay sir, for the presidential address. Vijay sir.
Join ചെയ്യുന്നുണ്ട്. Vijay Kumar sir, sir address sir.
Hello, sorry, കുറച്ച് late ആയി പോയി.
Sir address.
Welcome sir.
Respected Dr. Sakriya, the President of IAP Thalssery, and all the senior members and the speakers, Dr. Shrija and Dr. Nandakumar, and all the senior members like Parvati Madam, Dr. Johnny Sebastian, Secretary of IAP Kerala, Dr. Santosh sir is, I can see Dr. Santosh sir, and all the members. Sorry, I was little bit late because I had a one program. So this COVID related, pediatric COVID is a very important session now because of the re-emergence of COVID in the form of Omicron, and happy that it is gradually showing its receding trend. Since I think within few weeks you may see some cases of multisystem inflammatory syndrome in pediatrics. We don't know because last two waves we have seen pediatric cases after few weeks. So hope that the very good knowledge, solid knowledge among pediatric COVID is very essential in this time. So I wish IAP Thalssery, IAP and IMA Thalssery all the best, and we can hear the great talk because I have already heard this talk 1 week back, that it will be a wonderful talk and it will be an academic feast for everybody. All the best for this program. Jai Hind and Jai IAP. Sorry, I am a little bit late.
Okay, sir. Thank you, sir. Thank you for the nice words. Next, I invite our State Secretary, Dr. Johnny Sebastian, to address the audience. Johnny, sir.
Yeah. Good evening, all. Am I audible?
Yes. Yes.
Yeah. Respected Chair and my dear friend, Dr. Sakriya, my leader and State President, Vijay Kumar sir, Dr. Santosh sir, the past State President of IAP Kerala and our own branch member, seniors like past President Parvati Madam, our well-wisher in IMA Thalssery President, Dr. Mini Madam, the silent and hard-working Secretary of IAP Thalssery, Dr. Shyam, Dr. Aravind, Secretary IMA, esteemed speakers of the day, Shrija Madam and Nandakumar sir, seniors from IMA as well as IAP, and my dear friends in IMA as well as IAP. At the outset, I would like to congratulate the team of IAP Thalssery and IMA Thalssery for arranging this webinar on COVID-19 at the right time when we are going through the turbulent days of this third wave. As we all know, many of our dear and near ones are already down with this illness these days. Today, we have two excellent speakers to update us on various aspects of COVID management in children. I take this opportunity to express my heartfelt gratitude to Sheija Madam, who coordinated this project so well and came out with such an excellent PowerPoint covering all the aspects of COVID management in children. Thank you, Madam. Nandakumar sir, as we all know, is an expert in this field and has been handling so many cases of Misc in our part of the state. So I am sure this webinar is going to enlighten you all, and I request all of you to put forward your queries in your chat box as well as after unmuting, so that we can be more updated in COVID management in children. I wish this webinar all success and all the participants who are present here today a great learning experience. Thank you. Jai Hind, Jai IAP. Thank you.
Thank you, Joni sir. Next, I invite our past IAP State President, Dr. M.K. Santosh for the felicitation. Santosh sir.
Respected Thalssery Branch President Dr. Zakaria, State President Vijay Kumar, IMA President Dr. Mini Balakrishnan, State Secretary, the most vibrant State Secretary we have ever seen, Dr. Joni Sebastian, Speakers Dr. Sheija Sugunan Nandakumar, and respected seniors and my dear friends. Today, we have an excellent topic, that is COVID management in children. First topic is covered by Dr. Sheija Sugunan, my favorite speaker. I still remember her first IAP platform was in Thalssery in 2008 or so. And after that, she has done so many speeches in IAP platforms. And not only for me, many of the IAPians consider Sheija Sugunan as the most wonderful speaker. And last week, Central IAP platform could hold 500 people. I just entered in the right time, but I couldn't. And it was over before time, that is 10 minutes before the stipulated time. The platform was full with 500 delegates. She has got a peculiar style of presentation. She starts with the basics, and she will lift you through the intricacies of the topic to the molecular level. And she ends the topic with the latest data published last week in the International Journal. And next speaker is Dr. Nandakumar, our will handle
Sir,
it.
unmute. And sir.
I wish all of you a brilliant CME. Thank you. Thank you very much.
Thank you, sir, for the nice words. Next, I invite IMA Thalssery President, Dr. Mini Balakrishnan, for the felicitation. Over to you, madam. Mini madam.
Respected IAP President Dr. Zakaria, State President Vijay Kumar sir, today's faculties Dr. Sheija Sugunan and Nandakumar sir, State Secretary Vibrant Johnny sir, past State President Santosh sir, dear IMA and IAP members, and my dear leaders. Now it's a great pleasure for IMA to associate with IAP in conducting today's CGP chapter on COVID-19 management, a workshop, which is the need of the hour. Now, we all are aware of the COVID and its implications in all categories, but the two categories that we are worried are the pregnant ladies as well as the children. And as we said on the reopening of the school, we told that the third wave is not going to affect much of the children in serious forms, even though the inflammatory syndrome which occurs in around 5%. But as far as the gynec population is concerned, we are really worried, because the first wave we lost 7 mothers, the second wave we lost 93 mothers, and that was because of the Delta variant. And the fact that the confidential review of maternal death shows that of the 93 mothers, none were vaccinated. And that was the impulse to give a representation to the government in promoting the vaccination among pregnant ladies too. And the more complications in pregnancy that we come across are the 2 times higher risk of preterm, 3 times higher risk of preterm birth and 2 times higher risk of IUD, even though congenital malformations or transplacental spread is not that reported. And many are concerned about the breastfeeding postpartum also. So I think today's CME will really address all such matters, and especially the present in this present scenario of Omicron. And I wish the CME all success, and I also congratulate the IAP for bringing such a topic to the to all the pediatricians as well as our IMA. Thank you.
Thank you, madam. Now we are moving on to the scientific session. It's workshop on COVID management in pediatrics. To enlighten us, we have 2 eminent speakers. Dr. Sheeja Sugunan need no introduction to this audience. An excellent national speaker, eminent personality, and one of the main pillar of this COVID workshop. And now working as Associate Professor, SAT Trivandrum. Madam will discuss about acute COVID infection in children. The other speaker is none other than our Nandakumar sir, National Executive Member and a close friend of IAP Thalssery. And sir will discuss about the hyperinflammatory condition related to the COVID, that is Misc, Multisystem Inflammatory Syndrome in children. I invite Dr. Sheeja Sugunan for the talk. Over to you, madam.
Thank you, Dr. Sakriya, and thank you, Santosh sir, for those words. I don't really think I deserve those. So first of all, good evening, everyone, and thank you, IAP and IMA Thalssery branch for giving me this opportunity, especially the office bearers, Dr. Johnny Sebastian, Dr. Mini, Dr. Sakriya, and others. So straight away going to my topic. Okay, share the screen. I hope it's visible, right?
Yes.
Yes, okay.
Yes, madam. Yes.
Okay. So what I would be covering would be acute COVID-19 infection in children. So this was the team that was behind these slides and this venture of the Unicef IAP combined project. So I thank each one of them for the initiative that is really doing good things to Kerala right now. A timely initiative, I should say. And these slides were reviewed by Dr. Suresh, Dr. Riyaz, and Dr. Praveen. So coming to the fact that this was one of the headlines way back in 2020, and unfortunately, 2 years later, the same headline still is there. It still continues to be, COVID still continues to be the newsmaker. So as far as acute COVID in children are considered, we all know that in both the waves, children contributed to less than 12% of the cases reported. And the reason why we said that children were affected less, we had explained with multiple reasons. We said that it may be because of the age-related differences in expression, affinity, and distribution of AC receptors. It may be because their endothelium is less damaged. They have less comorbidities. There is less chance of vitamin deficiency. Vitamin D deficiency, which is supposed to have an anti-inflammatory and antioxidative property, and stronger innate immunity, higher melatonin levels, everything was attributed to a lower incidence of COVID infection in children. But when finally the Sero survey report came from various parts of the country and from the world over, we realized that our assumption that children were not getting infected was wrong. The fact was children were getting infected on par with the adults. The only difference was most of them was asymptomatic or mildly symptomatic. So infections were happening, but it was definitely not severe. And the reasons we mentioned for less infections in children also are applicable for why it is probably why it was less severe in children. And when finally the Omicron came, we were happy to find the statistics that there was definitely an increase in number of infections, but it did not really translate into increase in number of hospitalization and increased death. So that was a welcome relief. But over the last couple of weeks or days, now we are seeing the headlines which are telling that After the Omicron has come in, children are getting more and more admitted into the hospitals, whether it is from the US, from the UK, or from the Africa. The news has been the same, that children as a proportion are reaching the hospitals in a higher number compared to the adults. In fact, what the data from the Singapore says that children less than 12 years are starting to form the majority of cases admitted in the hospital. So having said that, as you can see here, the proportion of admissions, even though the absolute numbers may not be high, but the proportion seems to be higher in children compared to the older age groups. So initially during the when the acute COVID came, we all know that Omicron is in fact a far higher peak than the previous waves. And fortunately, the peaks very fast and also shows a rapid decline, probably because of the vast number it infects in a very short period of time. And thankfully, the increased number, as we know, has not translated into increased mortality. In fact, world over, the mortality due to COVID has come down. But very recent data, now the WHO is telling that mortality is showing a higher trend just because of the sheer number of patients who are getting infected with COVID-19. But still, it is nowhere near what we faced earlier. But many of the European states and European countries are now reporting 90 to 95% ICU occupancy. It just reflects the number of people getting infected in the community. A large number get infected, even if the numerator is small, because of the huge denominator, naturally, the number of admissions would definitely go up. Now, having said that, we all know regarding the mode of transmission, we know that it's mainly the droplet spread. That is why even now your mask, your hand washing has a role. And we also know that aerosol spread does happen, and chance of aerosol spread is more when you're doing aerosol generating procedures like CPR, nebulizations, intubations, etc. And that time probably you still need to take an extra care because you still have a possibility of getting infected while you're doing an aerosol generating procedure. But it's also important for us to remember that virus dies very quickly when exposed to sunlight, and the longest survival at room temperatures or below are at room temperature. So if you are in the sunlight, exposures happening in wide gatherings outside, the chance of spread is less if people are not really standing too close and causing a droplet spread. And also inside the halls, the chance of spread is definitely high. I think something that we all are aware of over the time. But what we need to now focus upon is that the maximum infectivity is 1 to 2 days prior and 2 to 3 days after the symptom onset. So that is important for us because we were told that you are infective 2 days prior to 8 days after onset of disease. It still holds true. You are infective close to 1 to 2 weeks after an infection, but the maximum infectivity is during the initial days. And that is the reason why the isolation period has now been decreased to 5 days with 1 day of febrile as far as CDC is considered. And our government of India says that your isolation period ends if you have isolated yourself for 7 days from the symptom onset and you have been 3 days febrile. But along with that, we also need to understand that there is one more caveat to that 7 days. That is, for the next 7 days, you would be wearing an N95 mask while you are in the public. So that is important. So we need to understand that we are allowed to go out without the antigen test. That is fine. But you still have, most of us would harbor the virus and your RT-PCR may still be positive or your RAT may still be positive, but your chance of infecting others is less, but please take precautions for the next 1 week too. Now, what are the clinical presentations of acute COVID in children? We all know that they would present with acute upper respiratory infection, lower respiratory infections in children. Diarrhea and vomiting are quite common, and they can also have atypical, especially neurological presentations like seizures, encephalopathy, and last but not the least, MISC. So what is different from Omicron and the previous COVID outbreaks was it is not causing much of loss of smell or loss of taste. Earlier, close to 50% would complain of that, and now it's only 10 to 12% are complaining of that. It is thankfully not infecting your lower chest or your parenchyma much, but you do complain of very bad sore throat. Irritant cough is a prominent symptom. And same is the case of very splitting headache, especially the adolescents would tell you that they are having a very bad headache. And myalgia, arthralgia, especially low back pain is very common symptom as far as Omicron is considered. But there is Something more to Omicron in children. As far as children are considered, there is an increased incidence of airway disease. And children having an airway which is inherently narrower than the adults. And whenever there is an infection happening and inflammation happening, they are more prone to developing tracheitis, bronchitis, bronchiolitis, and asthma exacerbations. So that is what we are definitely seeing in a higher number. And naturally, many of them are coming with very high fevers, 103, 104, which sometimes precipitate febrile seizures, febrile delirium. And part of them do manifest with GI symptoms like loose stools and vomiting also. And croup has been a revelation this time, because earlier episodes we have not seen a higher incidence of croup. And now you can see a very recent data published very recently, just last week. You can see from the US, you can see how the croup cases has really exponentially rose after the Omicron took over. So it is definitely affecting the airways. It is definitely causing airway diseases in children. And younger children are the one who are more getting admitted, especially less than 1 year of age, and that too usually with a croup. Now, what are the risk factors for hospitalization? The traditional risk factors are children less than 1 year and more than 10 years. We are not seeing much of older children. We are definitely seeing more of younger children, and in between ones who are dropping in with seizures. And children with chronic neurological disease, chronic lung disease, congenital heart disease, CKD, genetic abnormalities are definitely prone for higher incidence of infections, or severe admission as well as mortality. But during this wave, in fact, we are seeing more of normal children dropping in your ICUs, in your wards, rather than children with anomalies. It's only that if the children with anomaly gets it, the chance of it becoming severe is definitely higher. Obesity in teenagers and immunosuppressed state is also a risk factor, but thankfully, malignancy we are not finding as an increased, we are not seeing an increased incidence of mortality in that subgroup of patients. Now coming to the clinical severity of acute COVID. We all know that category A and B are essentially upper respiratory infection. They do not have any evidence of lower respiratory tract infection, whereas category C may be moderate, may be severe. If a category C patient has a saturation between 90 to 94 or has a tachypnea more than the age appropriate normal, you take it as a moderate disease. But if a child with evidence of lower respiratory tract infection in the form of tachypnea has a saturation less than 90% or any of the danger signs like inability to feed, grunting, lower chest indrawing, altered sensorium, somnolence, seizures, etc., it becomes a severe. I would like to add one point here. Remember, febrile seizure, even though you have to definitely rule out an encephalitis, we are seeing encephalitis also with acute COVID infections, but a classical febrile seizure, we don't have to really go do everything that you commonly do in case of a severe category C disease. ARDS, MODS, and shock would be included in critical category C cases. Having said that, now let's see a prototype case, a 4-year-old child brought with fever, running nose, and sore throat. On examination, child is alert with febrile with a temperature of 102, pulse rate of 120 with CFT less than 3 seconds, chest is clear, other systems are NAD. What would you like to do? According to old category, when you have a fever, the child lands up in category B. So what is your option for this? Would you like to send the child home, or would you like to admit the child, or provide him with a symptomatic treatment and explain the danger signs and provide a monitoring chart? It's most of the things you would do in this child. So how would you go forward with it? First of all, whenever you are getting a child with a COVID positive state, always look whether it is an upper respiratory infection or lower respiratory infection. Look for evidence of lower respiratory infection in the form of tachypnea, retractions, grunt. If these are not there, if patient's general sensorium is good, and there is no organ-threatening involvement in the form of shock, seizure, encephalopathy, you are definitely dealing with a mild disease. So once you have categorized it as a mild disease, look for the risk factors. If you don't have any risk factors, you can provide them with a symptomatic management and send them home after explaining the danger signs and also telling them what to look for monitoring in the baby. Meanwhile, if the child has risk factors, which would include any patient with a chronic illness, be it neurological, cardiovascular, especially lung diseases, then you may admit the child. Or if you are sure of the follow-up, if you are sure of how the caretaker is competent enough to take care of the child and how severe the child's comorbidity is, you may decide for admission or may advise a home care with a complete facility to contact the doctor over phone whenever it is needed. So, and what is the checklist that you would look for when you're deciding, okay, this child I can send home? So here you need to look that the mentation is abnormal. Do not send home a lethargic child. Do not send home an abnormally irritable child or a child who's not sucking at breast. And look for the hydration. If the child is passing urine at least once in 6 hours, it's okay. You can advise how to take care of hydration and send them home. And also, as we already mentioned, look for evidence of lower respiratory tract infection. So if all this, if you are ticking everything is normal for these 3 main parameters, you can advise a home care. And once you send the patient to home care, provide them with symptomatic treatment. You may give paracetamol 10 to 15 mg per kg per dose, 4 to 6 hourly. Tell them not to give it more frequently. You don't want children coming up with liver toxicity. That's quite common. As parents panic with the high fever, there's always a tendency to repeat the dose early. So ensure it's not happening. Advise them that hydration is important. Looking for the urine output is important. And supplementing electrolyte-rich fluid, be it ORS, Kanya water, whatever your traditional one. Plain water, I wouldn't recommend. And say that at least 10 ml per kg per purge should be advised. And monitor every 24 to 48 hours for worsening of symptoms. And if anything happens, they're expected to contact the hospital. Remember, no role for antivirals, no role for antibiotics, no role for investigations, no chest X-ray or CT scan for a child categorized as a mild disease. So, and this would be a template of monitoring child, especially if you have admitted a mild disease, but in category B, or the child is getting admitted in CFLTC, or any parent, they can look 4 times daily at these 6 parameters to see that the child is not developing a danger sign. From that, always, we already discussed the red flag signs, always emphasize on the red flag sign, especially inability to feed, increased lethargy, cold extremities, decreased urine output. Definitely ask them to come back to the hospital. And children with mild disease. Now, whom would you refer to the secondary care? We said that you can manage them at home. We said that you can manage them at CFLTC or CSLTC. Whom would you refer to as secondary care? A child who develops a tachypnea definitely needs a referral. If a child's fever is lasting beyond 5 days, now we are seeing that most of the fever, initially it's very high. It's for the first 2, 3 or 4 days and then it subsides. But if the fever is lasting beyond 5 days, definitely. Or if the child is showing features of hypothermia, or they have comorbidities or develop any of the danger signs we discussed earlier, the child should be referred. Now coming to the next case. It's a 3-year-old child, asthmatic. You're commonly seeing this now, who has got an upper respiratory infection, cough, and you have a chest bilateral wheezy present. So where does he come? Does he come under upper respiratory infection or lower respiratory infection? He's definitely in lower respiratory infection, but it is not a parenchymal disease. It is an airway disease. So if a child with a wheeze has a normal sensorium, has a normal respiratory rate with no marked increase in work of breathing, and his vitals are stable, you can definitely understand that this continues to be a mild category. There is no role for antibiotics unless you think there is a chance of coexisting bacterial infection, and there is no role for antivirals also. So this child would go home with the routine treatment that you would prescribe normally when you encounter a child with a wheeze exacerbation. So here, always remember that use an MDI with a spacer. I would say that we normally say if the child is more than 5 years, you can easily ask them to use the MDI with a spacer without a face mask. But I would say any child who has an acute exacerbation, even if it's an adult, if you are an asthmatic yourself, you would know that when you have an acute exacerbation, it's really very difficult to purse your lips around the canister or around the spacer and take a breath properly. Because most of the time when you are dyspneic, you tend to open your mouth and breathe through the mouth. And for that, having a face mask would be definitely desirable. So acute exacerbation, irrespective of the age, when you want to give a sympathomimetic drug like salbutamol as a reliever, please definitely consider using, along with the spacer, a space mask too. And MDI is always preferable because of the lesser risk of aerosolization and better delivery of drugs to the distal airways. Now, what about smaller children? Smaller children, we already said they may land up with croup. So when you want to give nebulization, yes, nebulizations may be given. And you can also improvise like this to ensure that the child is less disturbed, the child is getting the nebulization, as well as the chance of having aerosol inside your ICU or HDU would be less. A word about croup, because you're seeing that in a higher incidence is definitely being reported from every part. And whom would you suspect a croup? When a small child comes with a barking cough, when the mother says that the cough's character has changed, you should definitely think about a croup. So if the child is only having a barking cough, that means it is a mild croup without any stridor, just a barking cough. The child can be offered a single dose of corticosteroid, which may be dexamethasone, either parenteral or oral route you can offer. And you also know that this is a very tasteless tablet, so it is easy to administer to a small baby. Single dose, observe the child is okay, you send them home, telling them the danger signs. But on the other side, if the patient has an audible stridor, you remember, if the stridor is audible only when the child is crying, that means the airway narrowing is not that significant. Whereas if the stridor is audible even when the child is calm, that means the airway narrowing is much more severe, because in the first instant, the stridor is happening only when you are forcing in a lot of air through the narrow opening. In the second instant, even a normal airflow through the narrow orifice is causing a stridor. So stridor in a calm child is definitely a danger sign and would preferable to be admitting the child. Whereas stridor in a crying child, you can offer them Dexa 0.6 mg per kg and then observe for 6 hours. If the stridor is there, you can initially itself give an adrenaline nebulization 0.5 ml per kg with a maximum of 5 ml. And whether you give adrenaline nebulization and steroids, wait for 4 hours. In nebulization, adrenaline nebulization effect would wane off in 1 hour, whereas a steroid effect will take time to appear at least 2 hours. The action would peak at 4 hours, but at least 2 hours. And that is why you say that wait for 4 hours, so that you see that the action of steroid has come in, the child is responding, there is no stridor at rest, the baby is comfortable without any retractions and feeding well, you can send the child home. But if the stridor is persisting at 4 hours after you have given dexamethasone, or at the admission itself, there is a stridor at rest and there are retractions, it is always preferable to admit the child. But sometimes the question comes that this is an acute viral infection, and during the period of viremia, do you want to start steroids so early? The answer is croup responds best to parenteral steroids. Even though it responds to adrenaline, the response is short-lived. And the traditional croup that follows the parainfluenza virus is also a viral infection. So we needn't worry about it, because you're just giving a single dose to ensure that the anti-inflammatory activity is there for a longer time, not causing much of an immunosuppression. From there, during aerosol therapy, always remember, when the child is requiring a nebulization and you're providing a nebulization, a mask alone is not enough. You need to have a protection for your eyes too. Goggles is better, or at least a face shield should be there, because mucosa also contains AC receptors and the virus can enter through there. Now, what about children with moderate disease? So a child with a moderate disease is someone who's having a tachypnea or someone who's having a saturation between 90 to 94%. So this child will definitely require admission. He does not need to be referred to a tertiary care hospital. He can be managed in a secondary care hospital. What would be a level 2 care hospital would be somewhere where you can provide at least 5 liters per minute of oxygen to maintain a saturation more than 95%. It would be considered as a level 2 hospital where this child can be admitted. And in a level 2 hospital, it is not mandatory that the pediatrician is in the hospital round the clock, but there should be a medical doctor, and the pediatrician or an internal medicine specialist should be available on call. That is what the requirement of a secondary level care is, according to the Ministry of Health, Government of India. And this child naturally would require admission, administration of oxygen, monitoring of vitals, And the preliminary investigation would involve a blood glucose, a CBC with a chest X-ray. We're not going for any further investigations. Here again, there is no role for antivirals, no antibiotics unless you're strongly thinking a secondary bacterial infection, and steroids only if there is a rapid deterioration and more than 5 days since the onset of disease. So as you can see, we are a step behind when it comes to lower respiratory tract infection and steroids compared to the adults. So only if there is a rapid deterioration and the child is already more than 5 days from symptom onset, would you think of giving a steroids. And when you're providing nasal prongs for oxygen, remember, it is according to the child you decide how much maximum flow you can give through a nasal prongs. For a neonate, it's preferable to limit up to 1 liter, for an infant up to 2 liters, for an older child up to 4 liters, and for a school-going child or adolescent, you can go up to 6 liters, which is the maximum recommended for the adult. And a surgical mask over the prongs for children, especially above 5 years, would definitely be desirable. Then if you are working in a peripheral setup, you do not have a nasal prongs, you just have adult things, then you can use a simple 8 French catheter, be a suction catheter, be a feeding tube, and see that the length that is inside the nose is equivalent to the length distance between the side of the nostril to the inner margin of the eyebrow. And so here the important is that the nasal prong should not be visible below the uvula. So you are just trying to keep it as a nasal catheter, which goes little too much inside the nose, but not exactly coming to the throat. And in case you want to put an NG tube, it is not mandatory that you put an NG tube. In case you want to put an NG tube, it is recommended that you put it through the same tube. Why do they so? It looks a bit inhuman to have 2 tubes in the same nostril. The reason here is that whenever you are using a nasal catheter, the chance of it getting blocked is high. So if you are blocking both the nostrils, it may become very difficult for the child to breathe in case the catheter becomes blocked. So that is the reason you want to keep one nostril free while you are inserting the catheter and NG tube in the other. Then moderate disease, while you're monitoring, especially along with the vitals and the SpO2 that we all would be monitoring, please monitor the sensorium and the work of breathing. That is very, very important, work of breathing. So even if the saturation is more than 95%, if you find that there is lower chest indrawing, if you find that the alienaceae are flaring, you should know that it is no more a moderate disease. It has become a severe disease and definitely refer to a tertiary care hospital. So secondary care, we are managing children with tachypnea, but those are children who would be tachypnic but relatively happy without any retractions or any danger signs. Now, in this subgroup, we already said we want to do only a CBC and chest X-ray. But in case you find that the child is not responding as good as you wanted it to be, or the disease seems to be lasting for more than 5 days, then definitely you're justified in sending a CRP, D-dimer, and ferritin to see that if the cytokines are going up or not. Now, coming to severe disease. So severe disease would be someone who would definitely be managed in a level 3 care, that is a tertiary hospital. So who is having a severe disease? Any child who's having a saturation less than 90%, anyone with danger signs, and anyone with an organ threatening disease. This is one group where you would definitely give an empiric antibiotics, and you would be thinking of giving a steroids too. So we'll be coming to the steroids shortly. And remember, unlike the adult, where you would use a non-rebreathing mask for those with lower respiratory infections, in children, we do not prefer to continue with an NRM for a long period, because NRM is the source of oxygen that has a very high FiO2, and you would miss worsening of a child. And remember, if a child is not responding to NRM, there is nothing else for you to escalate as far as oxygen delivery is considered. You would be forced to intubate, or an NIV would only be beneficial at that point. So if you're working in a secondary healthcare, always, as we already said, the best is manage up to nasal prongs with the adequate flow. And if the saturation is not maintained, refer to the tertiary care. In the tertiary care also, we are expected to follow a stepwise escalation of oxygen support, but NRM would be a best option when you are getting a very sick child in a peripheral setup and you want to refer them on a tertiary center, because this provides you with a higher FiO2, and so on the way also the child going in for a hypoxia would be less. So any sick child, anytime, refer on an NRM, that is the best, but ensure your cylinder is full and if spare cylinder is there, because NRM would require at least 10 liter per minute flow. You have to ensure that the bag is inflated all the time, so your cylinders may get empty early. So that thing also needs to be kept in mind. Now, when it comes to a tertiary care hospital, so this is a patient who's not been, you are not getting the desired effect with the nasal prongs. So the next best thing would be going for a high flow nasal cannula. There are two methods by which HFNC can be offered. Remember, as far as children are considered, unlike the adult where you can go up to 50 to 60 liters per minute, children have an upper flow limit according to the age. In a newborn or in a premature, the maximum flow is 8 liters per minute. For an infant, you can go up to 20 liters per minute. And for a pediatric, you can go up to 25 liters per minute. Please remember, unlike the CPAP nasal prongs, whenever you are using HFNC in a child, it is important that you use the appropriate size of the nasal cannula, the color-coded one, because your nasal orifice should be blocked only 50%. So that's important. When you are using a bubble CPAP, we try to keep the largest possible nasal prongs so that the PEEP is delivered. But when you are keeping an HFNC, remember, you're giving a very high flow. And when you're giving a very high flow, you have to allow the baby to expire. Otherwise, you may develop having air leak syndromes like pneumothorax. And for the baby to expire, it is important there is space around the nasal cannula. And that is the reason why you have color-coded sized nasal cannulas. And remember, it should cover only 50% of the nasal orifice of the child. Having said that, we all know that you start with a lower flow, start with 0.5 to 1 liter per kg per minute, unlike in other situations where you directly usually go to 2 liter per kg per minute. Observe every 15 minutes and reassess after 1 hour. If after 1 hour of HFNC, the child is not showing improvement, it is better to consider an NIV. What do you mean by improvement? Remember, the saturations would improve when you're giving oxygen, but the work of breathing is not going to come down immediately. What comes down first is in fact the heart rate. So if you have a heart rate fall by 20% within 1 hour of keeping an HFNC, you should know that the child is responding to HFNC. You should give him a little more time on HFNC. Slowly the respiratory rate would also come down. And if the patient on HFNC requires a nebulization, we already said that our children are going to come with an airway disease. HFNC is not a great mode of oxygen delivery in a case of asthma, because if you are giving too much flow through an HFNC and you are keeping a nebulizing mask in front, the nebulizing solution would find it difficult to enter the airway, because all that is going in is the HFNC air oxygen mixture that is going in. So in that situation, if you're using an HFNC for a child with asthma, it is preferable to have a nebulizer sitting at the level of the humidifier from where it can directly enter the circulation. So that is one point you have to remember. And in case you're using an HFNC and you want to give a nebulization, then decrease the flow to 2 liters and then provide the nebulization. Only then the nebulizing solution would find its way, the aerosol would find its way to the lower airways. And bigger children, definitely again, thinking of providing a mask would decrease the aerosolization in the unit. And when the child is better and child is having a saturation more than 92%, first try to wean the FiO2. And while you reach the FiO2 of 40%, then try to wean the flow. So if the child was on 2 liter per kg per minute, come down to 1 liter per kg per minute. And if the child is stable for 2 to 4 hours, again come down to 0.5 liter per kg per minute. And if there is no hypoxia, you can directly wean the patient to room air. If there is hypoxia but no increased work of breathing, you can wean them to simple nasal prongs and subsequently to room air. So that is how you normally wean. But in case your child is not responding to HFNC, the tachypnea is persisting, the hypoxia is not improving, then you have to definitely think of NIV. Dedicated single limb NIV is usually not preferable because it causes a great aerosolization. So would be preferable to use a dedicated invasive ventilator to provide an NIV using a oronasal mask. Here, remember, start with a CPAP mode, reassess after 1 hour, reassess at 1 hour and decide whether the child requires intubation or not. And if the child is not responding to the CPAP mode, definitely you can go to the BiPAP or even the PCV mode as far as children are considered. And if they're not responding to NIV, intubation is definitely an option. Now coming to severe disease management, the other management is definitely the supportive management. We already said about the respiratory, hemodynamic support also needs to be provided. What about the steroids, anticoagulation, and antivirals? Remember, start steroids only if it is 3 to 5 days after the onset of disease, as it prolongs the viral shedding. Severe disease and moderate disease with increasing oxygen demand, definitely steroids can be offered. And what is recommended is a DEXA in a dose of 0.15 mg per kg as an OD dosage. And if instead of DEXA, you want to give methylprednisolone, you can give in a dose of 0.75 mg per kg with a maximum dose of 30 milligram. Methylprednisolone can also be given as OD dosages, but when you know the kinetics, the pharmacokinetics, you know that methylpred would be better to be administered as a BD dose rather than as an OD dose. Continue to the steroids for minimum of 5 days, 5 to 7 days, and the taper over 10 to 14 days. So usually you're stopping the steroid by 10 to 14 days if the child is otherwise normal. Now, what about prophylactic anticoagulation? We do a lot of prophylactic anticoagulation as far as adults are considered, but as far as children are considered, we have taken a step backwards. It is not routinely recommended in children. So whom would you give? You would start a prophylactic anticoagulation with enoxaparin 0.5 milligram per kg BD. If for a patient with a strong family or personal history of thrombosis, or someone who has an indwelling central venous line with 2 or more additional risk factors, or someone who has a D-dimer more than 5 times the upper limit of normal. Remember, D-dimer more than 5 times of the upper limit of normal is only applicable for admitted children. And in fact, it is not one of the criteria for anticoagulation according to Ministry of Health, but other bodies usually recommend it like that. So what are the risk factors for thrombosis? We already said family history of VTE, personal history of thrombosis, presence of a central venous line, presence of ejection fraction less than 35%, or burns, decreased mobility, premorbid obesity, all would be risk factors for thrombosis. Now, avoid anticoagulation if there is an active bleed, IC hemorrhage, or you're planning a CSF study in the next 24 hours, neurosurgery procedures, and intracranial mass lesions or thrombocytopenia and deranged PTINR, definitely anticoagulation would not be indicated. So see to it that none of these are there in a child you're planning to anticoagulate. And therapeutic anticoagulation is only when you have a confirmed thrombosis or when you have an ejection fraction less than 35%. So that was regarding anticoagulation. Now coming to the last part of the severe one, that is remdesivir. We know that remdesivir is not routinely recommended, especially for children and even for adults, because WHO has given a conditional recommendation against the use of remdesivir. Remember, it can cause hepatic derangement. So if your liver enzymes are more than 5 times the upper limit of normal, it is definitely not indicated. And there is definitely no role beyond 10 days. And all this is because the efficacy is doubtful. So this is what we have been telling repeatedly. But is there, and as I already said, WHO has given a conditional recommendation against using remdesivir, and Ministry of Health in the latest guideline published very recently has recommended against using remdesivir in children. But do we have any latest evidence? Now we know that it may be beneficial when given early in the course of disease for those above 12 years with risk factors. So many of the institute with very high risk factors like premorbid obesity, like those with uncontrolled diabetes, for those who are malignancy patients, and for them, we know that your MAB is definitely not effective. And a 3-day course of remdesivir may be considered in those patients because it has been found that it causes 87% relative reduction in admission as well as death. So that is a newer addition to the role of remdesivir. And that is why the FDA very recently on January 21st has released a recommendation telling that when given early in the course of disease for those above 12 years, it decreases the risk of admission as well as mortality. And it is now approved for the treatment of non-hospitalized patients at high risk of disease progression. And about the pediatric population, it has given an emergency use authorization to include treatment of non-hospitalized pediatric patients at high risk, again for those above 12 years of age. They have also said that for those below 12 years of age and those who are hospitalized, probably especially within the first 10 days or 5 days of disease onset with severe disease, after consultation with a pediatric infectious disease, it may be an option. So what do we know till now about remdesivir? We understood that remdesivir is not routinely recommended, but we also understood that very early in the disease, in certain special situations, especially for those above 12 years, remdesivir may have a role. And what about monoclonal antibodies? It is not routinely recommended in children as evidence, as there is insufficient evidence. Even the emergency use authorization by CDC is only for those above 12 years and for those above 40 kg. And as far as we are considered, we know that the currently available monoclonal antibody in India has absolutely no role for Omicron because it targets the spike protein, and the spike proteins has gone a lot of mutation as far as Omicron is considered. So MAB is definitely not something that you would be considering in a child. So I think I will not touch upon Misc because it will be taken by Dr. Nandakumar, because all I wanted to say that even when a patient is COVID positive, even when a patient is rat positive and coming to you, but if he has features, please do look for concomitant features of Misc, which would include conjunctival changes like congestion or even a bleed, or which may include various types of skin rashes or oral mucosal congestion. So these patients and unilateral lymphadenopathy do think of Misc because Misc can coexist with acute COVID infection also. So the final take-home messages are, coming weeks, we may see more children getting admitted with COVID-19, especially with airway disease. Remember, COVID pneumonia, lower respiratory tract infections with COVID is definitely rare. Croup, bronchiolitis, GI symptoms, and febrile seizures are what we are anticipating and seeing right now. There is no definite role for antivirals, tocilizumab, and convalescent plasma. Steroids are indicated beyond 5 days in most cases of severe diseases, and Misc should be suspected in children presenting with fever with multi-organ dysfunction. Thank you. And these were the references, and I really hope that, and we really need to remember that it is not yet time to remove our mask, and we really hope that അവസാനത്തെ ആളിക്കത്തൽ ആയിരിക്കട്ടെ ഇത് കോവിഡിന്റെ. Thank you.
Thank you, madam. Thank you for the information and excellent presentation. Next, we are move on to the second topic, that is Misc, multisystem inflammatory syndrome in children. For that, I invite Dr. Nandakumar MK. Over to you, sir. Nandakumar, sir.
Yeah, sharing. 1 minute. Not coming. One minute. Slides are visible?
Not visible.
Illa sir, not visible.
Not able to open it. One second. Is it visible?
No. വന്നിട്ടില്ല.
Not visible.
ഇല്ല.
Sir, ഇപ്പൊ ഷെയർ സ്ക്രീൻ ഇല്ലല്ലോ. ഷെയർ സ്ക്രീൻ ആയിട്ടില്ല. സർ ഒന്നും കൂടി സ്റ്റോപ്പ് ചെയ്തിട്ട് ഷെയർ സ്ക്രീൻ ചെയ്യുന്നു.
Okay, okay, okay.
സാറേ പറ്റുന്നില്ലെങ്കിൽ ഞാൻ ഷെയർ ചെയ്യാം ഇവിടുന്ന്.
ആയിക്കോട്ടെ എന്നാല്. ഓക്കെ ഓക്കെ
ചെയ്യട്ടെ സാറേ.
ഓക്കെ ഓക്കെ അതായിരുന്നു. Good evening, respected President, State IAP, Dr. Vijay, President IAP Thalssery, Dr. Sakaria, IMA State Thalssery President, and other dignitaries on this platform. First of all, let me thank IAP Thalssery and IMA Thalssery for giving me this chance to discuss very important topic, that is MISC, that is Multisystem Inflammatory Syndrome in children. As you all know, already Dr. Srija Sohn has discussed, Multisystem Inflammatory Syndrome is a very important. We cannot discuss COVID without multisystem involvement, discussing multisystem MISC in children, because MISC is one of the most common and most serious complications of COVID in children. So we started seeing this, reporting this since 2020 April, but in India we have started seeing June 2020, and our hospital we first case reported in October 2020. After that we have seen almost around 69 cases. And next slide please, next slide. So let me first thank Dr. Suma Balan and her team for preparing such a beautiful PowerPoint. And what is MISC? Next slide, please. As the name denotes, MISC is Multisystem Inflammatory Syndrome in children. Multisystem means more than one system. So usually occurs 3 to 4 weeks after peak of COVID-19 in community. It's not due to direct viral injury. It is an immune-mediated hyperinflammation. It is due to immune reaction following COVID-19 infection. So it can coexist with the COVID-19 infection also. Around 1/3 case can coexist with the COVID-19 infection. So when to suspect MISC? So any child, according to WHO, any child less than 19 years, but according to CDC, they have gone up to 21 years. So first and foremost thing is high-grade fever lasting more than 3 days. And usually, as you all know, during fever, the viral fever, common viral fever, child will be normal during interfebrile period. But in MISC, child usually sick. They will be very sick during interfebrile period. And response to paracetamol also is usually very, very poor as compared to other viral infections. Then other features are typical features of multi-system involvement. That's more than system. The most common system involved are skin and mucous membrane, abdomen, then lymph node, and cardiovascular system. And in WHO criteria, they are not included respiratory symptoms, but CDC, they have included respiratory also. And over that, it's markers of systemic inflammation. It may be clinical or lab investigations. Then, most important thing is there is we have to prove the temporal link with the COVID-19 infections. Then, the most important thing nowadays, which is this thing, is that before diagnosing, confirm the diagnosed MISC, we have to rule out other causes of fever. That will come to this point later. Then WHO case definition already we discussed. With children and adolescents less than 19 years of age and fever lasting more than 3 days, usually high grade fever, and child usually very sick, and involvement of 2 or more systems as evidenced by rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation signs, the inflammation of oral cavity, hands or feet. Then hypotension, cardiac involvement as evidenced by hypotension or shock. In features of myocardial dysfunction, clinically manifest as pericarditis, valvulitis, or coronary abnormalities. Can be lab investigation like echo finding or elevated troponin NT-proBNP. Then evidence of coagulopathy as evidenced by increased prothrombin time, partial PTT, elevated D dimer. Then acute gastrointestinal problems like diarrhea, vomiting, or abdominal pain. This is very common in Misc. Just like acute COVID in pediatric, these gastrointestinal symptoms are very, very prominent in Misc. And sometimes 8% as acute abdomen, and many times this can be very confusing features like acute can present like acute appendicitis with peritonitis. And an elevated marker of inflammation such as ESR, CRP, and procalcitonin. And foremost, I already mentioned, foremost important thing is we have to rule out other causes of microbial other causes of inflammation, including microbial, bacterial sepsis, staphylococcus, streptococcal shock syndromes, and we have to prove the association with the COVID-19 infections as evidenced by positive RT-PCR antigen test or positive antibody test, or even the contact with the recent contact cause household contact is also enough. Then coming to this picture, this neural signs. This you can see neurological signs 56% presence in neurology. What are the common neurological? Irritability. The child will be very irritable. Child will be very apathetic sometimes. Often that, or child be very rarely child can go for convulsion. Then fever already is almost 100% can present with fever. Then conjunctivitis, 90%, around 94% conjunctivitis. Then red and that is cheilitis or even stomatitis. Cervical adenopathy, you can unilateral cervical adenopathy, 37%. And sometimes when we have case, we have got referred cases such cervical adenitis not responding to usual antibiotic treatment. Then cardiac involvement as evidenced by coronary dilatation, then pericarditis, myocarditis. Then 86% can go for severe symptoms. Then GI symptoms. That is also one of the most common symptoms is GI symptoms. Then I will just show then edema of hands and feet can present. Then our series, in our hospital we have, I already mentioned we had 69 cases already. In that case, in our series, we got fever 100% we got. Then next is conjunctivitis, 64% present with the conjunctivitis, and around 70.45% is present at vomiting, and oropharyngeal changes occurred in 64%, diarrhea in 68%, then abdominal pain in 58%, rash, shock is coming like that. So present, I think this status is almost similar to this presentation. Next slide, please. Then one of the most common differential diagnosis of MISC, especially in small children, is Kawasaki disease. So MISC, usually Kawasaki disease occurs in less than 5 years of age. And compared to that, this MISC in Indian studies usually occurs in around 5 to 6 years of age. Then GI symptoms are common in MISC, but it is very unusual in Kawasaki disease. Myocardial dysfunction and shock. It is more common in MISC, but cardiac manifestation of Kawasaki syndrome is usually coronary dilatation, and except in 5% case of Kawasaki disease, or the Kawasaki shock syndrome, myocardial dysfunction is rare in cardiac Kawasaki disease. Then blood test, the inflammatory markers are very high both in MISC and Kawasaki disease. What is the difference? Because usually in MISC, the CRP will be these very high. We can get in 300, 400 in that. But in Kawasaki disease, the ESR will be more higher than CRP. That is what we used to get in our case standard. Then total count will be usually, initially there will be total count will be low in MIC, but later on as you start treatment, the leukocytosis occurs. Then initially it will be lymphopenia. Lymphopenia, total leukocyte count will be less than 1000. Then platelet elevation is less. Usually, initially we can get even thrombocytopenia in MIC, but Kawasaki disease, this thrombocytosis is the hallmark. Then coronary artery aneurysm is more in, as I already mentioned, this Kawasaki disease, but coronary aneurysm is compared to Kawasaki, it is less than MIHC, and severe aneurysm is usually compared to Kawasaki. We won't get severe coronary dilation. We are getting myocardial involvement more in MIHC than Kawasaki disease. Next slide. Then this MISC is a great masquerader, as you know, because it can mimic so many conditions. That first and foremost, especially in knowledge, we have to rule out bacterial sepsis. So then Kawasaki is already discussed. Then toxic shock syndrome, either staphylococcal or shock, streptococcal. Then we have to, in our country, like India and tropical countries, we have to rule out other tropical fevers like malaria, dengue, typhus, enteric fever, and every cases we have to rule out dengue. We have to rule out dengue, enteric fever, and strep typhus, and like that. In appendix, I already mentioned it can present as an acute appendicitis. So if you are very, very suspicious about it, you may have to go for CECT abdomen to rule out acute appendicitis, differentiate between acute appendicitis and MISC. Then other viral infections, we have to, especially Epstein-Barr virus, cytomegalovirus infection, we have to rule out. Then vasculitis syndromes. Next slide, please. Then how to evaluate a case of MISC. Then history and clinical examination is very important, as I already mentioned, history of contact to COVID, then any COVID-19 link, that is any contact to COVID-19, the past history of COVID within 3 months, whether the child had any contact with a non-case of COVID-19 or a child had any fever in the family, any other family members fever, then presence of shock or organ syndrome. And the most important thing, all children with fever can be MISC. But all children with fever may not be MISC. So especially in this scenario, you all know that the seroconversion is very high. It stands above 50%. So any child can, as Dr. Sirasogana already mentioned, any febrile seizure. Today we had 2 febrile convulsions children, but both were turned out to be COVID positive. So COVID positive and COVID antibody positive is very, very common in our community. So any child coming to presentation multisystem involvement COVID just because of COVID antibody positive, we cannot diagnose as COVID MISC. So we have to rule out other cause for hyperinflammatory syndromes. Then how are going to investigate a case of MISC? So all following, and we already mentioned, any fever more than 38 degrees centigrade lasting more than 3 days, and clinical features of multi-system involvement. Then with COVID-19 link, if it is there, then look for shock and life-threatening manifestation. If these manifestations are there, then we can simultaneously go for tier 1 and tier 2 tests, that which we will discuss later. And if these tests are fulfill the criteria for MISC, then definitely we can treat it as MISC. Otherwise, if you waste time, definitely child is going to be, its condition is going to be very, very serious. If criteria is not fulfilling criteria, we have to look for alternative diagnosis. Then if child is not having the features of a typical clinical, we do tier 2 investigation. If tier 1 investigation supports, definitely we can go for tier 2 investigation, and we can confirm the diagnosis of MISC, or we have to look out for other cause for hyperinflammation. Next slide, please. Then what are these tier 1 and tier 2 investigation? Tier 1 tests we can do in almost any hospital in Kerala at present, because it include complete blood count, then metabolic studies. What metabolic study what we use is, we can use this, no need for doing all LFT, you can go for SGPT and OT, then you go for serum albumin, because hypoalbuminemia is very common in MISC. Then in serum electrolytes, we can do sodium, because hyponatremia is also very common in MISC. Then CRP, as I already mentioned, CRP is very high in MISC. Then ESR also we have to do. Then COVID-19 testing, that is antigen test. If you are suspecting, we can go for RT-PCR. Then serology we have to do. COVID antibody test we have to do. Then blood culture to roll out any bacteremia or sepsis. Then to roll out other fever, we have to roll out other fevers like common tropical fevers like dengue fever, leptospirosis, malaria, then even we have to typhus fever we have to roll out. Then if this tier 1 in tier 1 test supports a diagnosis of MISC, you have to go for tier 2 investigation like cardiac, like ECG, echo, NT-proBNP, troponin, and inflammatory markers like procalcitonin, ferritin, prothrombin, APTT, D-dimer. Because if it's in a resource limited condition, no need for doing all these investigations, but important investigation we can do. Then blood smear you have to do. If patient with a shock and myoclonus, at least we no need of doing everything, but according to this, your discretion and the patient's financial condition also we have to see. Then CRP is, if then tier 1 investigation, if CRP is more than 5 milligram, in our hospital it's milligram per deciliter, so if it is more than 50 and ESR is more than 40, we have to suspect MISC, and at least one of these criteria, that is absolute lymphocyte count less than 1000 and platelet count less than 1.5 lakhs, then hyponatremia, that sodium less than 135, and neutrophilia, hypoalbuminemia is also very common in MISC. Then SARS-CoV link, like as evidenced by RT-PCR, antigen or COVID antibody test, then close contact with the case of COVID-19 infection. Next slide, please. Then after confirming the diagnosis, coming to the managing, how can we how are going to manage a case of MISC? So first and foremost, we already discussed. First thing is to see whether child is sick or not. A sick child with shock or life-threatening features like multi-organ dysfunction, definitely you have to refer child to a level 3 care center where PICU care is a must. So without PICU, you cannot manage that case. So before the referring, you have to try to get a good IV access and broad spectrum antibiotic, because we have to differentiate whether we don't know whether you cannot confirm whether this is a bacterial sepsis or not. So within first hour itself, we have to do the first dose of antibiotic. We have to, then RT-PCR positive MIS patient have to manage in a COVID care facility, that is separate COVID. We have to do facility for managing the COVID positive children. Then MISC with the shock. MISC with the shock, this drug of choice is IVIG. How will we give it? 2 grams per kilogram body weight over 16 to 18, 12 to 18, 16 hours. In our hospital, we are giving 16 to 18 hours. So maximum we can give 100 grams. So another drug is IV methylprednisolone. So the IVIG will take time. It will take 16 to 18 hours. So first and foremost, if child is in shock, the first drug which we prefer is methylprednisolone. Because methylprednisolone, if child is in severe shock, better you can go for 10 to 30 milligram per kilogram, maximum 1 gram. So after that, along with that, we can start IVIG also. So empirical antibiotic already mentioned. All cases we have to start antibiotic. So if early worsening is there, symptom persist more than 48 to 72 hours, then we can increase the dose. Already, if you have already given a low dose, you can increase the dose to 10 to 30 milligram, or we have to consult a specialist, or definitely we have to call other experts and we have to discuss about starting biologicals. Then MISC with Kawasaki phenotype, definitely the drug of choice is IVIG, that is 2 grams per kilogram over 12 to 16 hours. And IV methylprednisolone. In this case also we can start IV methylprednisolone in the dose of 2 milligram per kilogram body. And patient already mentioned if in shock or something like that, we have to give for higher doses. And early version, that is persistent symptoms more than 48 to 72 hours, and inflammatory markers are not coming after 72 hours. Definitely we have to think about starting biologicals like infliximab. One cases in our series, we started infliximab. Then the most difficult thing to diagnose is MISC without shock. This is definitely we are in confusion what to do. So ensure this case is, because we are not in hurry. Definitely you take your own time to confirm the diagnosis MISC, and we have to rule out the other cause for fever and this presentation. So this case we can give low dose IV methadone, right? 2 milligram per kilogram per day IV methadone. And if it is early worsening, and we have to we can evolve because it can present as KD type, or it can go for shock syndrome. Then we have to manage accordingly. So 1/3 case of patient can be RT-PCR positive. That case we have to manage separate COVID care center. Then you use biologicals only after expert consultation and tertiary care on, because especially people tend to give this tocilizumab in infliximab, and so before starting this biological, definitely we have to consult the expert. We have to over the phone, or if you have to refer to other centers. Then what are the other aspects of management? Supportive management, that is appropriate supportive care for manager cardiac dysfunction, coronary enema, shock, or multisystem dysfunction is also very important management of MISC. So IVIG can be given slow. There's already over 48 hours. If children with the cardiac involvement, definitely if you give very fast within 12 hours, and sometimes volume overload can tend to happen. So in that case, you can give it very little more slowly. That is, you can take up to 48 hours. So you can give 1 gram per kilogram within 24 hours, and next 24 hours you give another 1 gram. The total 2 grams you can give. Then consider effective ventilation if severe cardiac dysfunction is there. Then after that, now how are we going to taper this steroid? So usually after once CRP become normalized, that is less than 5 or something, then you can slowly taper and stop steroid over 3 to 4 weeks. Then another drug is aspirin. That is aspirin usual doses is the antiplatelet dose we have to give. That is 3 to 5 milligram per kilogram body weight per day, maximum up to 75 milligram per day. Then if important thing is we have to monitor platelet. If platelet count is more than 80,000, we can start aspirin, or minimum we have to give it for 4 to 6 weeks, or longer if there is any coronary involvement or coronary aneurysm, we have to give for little more longer time. So what about low molecular weight heparin like enoxaparin? Enoxaparin use is very limited, as Dr. Sugan already mentioned. If there is a coronary, that is set score is more than 10, or there is a demonstrated thrombus, or if this LV function is less than 35%, we can start low molecular weight heparin, that is enoxaparin. Otherwise, there is no need for starting low molecular weight heparin in pediatric age group. Then how to follow any cardiac involvement? If a child is shocked or a child is having LV dysfunction, definitely we have to repeat. We may have to repeat more frequently. Within 24 hours, you have to report. We have to monitor the LV function. So if it is not so severe, if a cardiac involvement is there, usually what in follow up that before discharge we can do 1 echo. Then 2 weeks we can do, after 6 weeks also we can do 1 echo. And if there is we are suspecting any cardiac involvement, even after 1 year we can repeat 1 more echo. Next slide, please. So when to refer a child with MISC to higher center? Say any child coming with multi-organ dysfunction or shock, that child needs a dedicated pediatric ICU care. So definitely you have to refer the child to higher center. So your unusual features like abdominal pathology, appendicular mark, intussusception, then bradyarrhythmia, seizure and encephalopathy, renal failure, pancreatitis, and very unusual rashes. These cases we have to refer as early as possible, because once it started deteriorating, the rate of deterioration is very, very fast, and we should not waste time for all this. Then children with existing morbidity, for example, heart disease, immunocompromised children, we have to refer early to a higher center where they can manage accordingly. Next slide. So to conclude, early diagnosis of MIS is very important, because each hour, once each child is going for shock and everything, each minute is very important. So once you suspect and diagnose the case of MIS, if you cannot treat that case in your center, definitely better to refer as early as possible. Then early commencement of immunomodulation are appropriate supported therapy critical for good outcome. So early, once you confirm the diagnosis, as early as possible, you have to start immunomodulation with the IVIG and methylprednisolone. And supportive therapy as oxygen therapy and other supportive therapy is also very important. Then combination therapy with IVIG and steroid provide better outcome in sick children than either alone. Then ventricular function tend to improve and proceed to normalization if you treat this early. So coronary abnormalities need serial evaluation to track normalization. Renal failure, seizure, and pancreatitis are poor prognostic factors, and with all this, the mortality is usually very low, that is 1 to 2%. And the most important thing is early diagnosis and early referral and early introduction of anti-inflammatory drugs. So sources are given you, and thank you very much. And any doubt we can discuss.
Thank you, Nandakumar sir, for the excellent talk. Queries? Santosh sir?
Hello.
Hello, Santosh sir.
Hello. Hello.
Hello.
Is there any difference in the management of multisystem inflammatory syndrome due to COVID or and other causes like dengue fever? If there is a gross difference in the management?
Sir, is MISC, the MISC terminology, MISC is exclusively for multi-system involvement due to COVID-19.
COVID, okay.
Yeah, because dengue and all is not coming here. That is a separate entity, sir.
Okay. Similar picture can be occurring the dengue fever and other.
So dengue fever can present as dengue shock syndrome. Other separate management is definitely entirely different. It is not, because that case we are not using IVIG or we are not, that's fluid management, mainly that fluid management.
മനസ്സിലായില്ലേ?
Any other queries? We can wind up. There's no
Vote of thanks.
Yeah.
Vote of thanks.
So we can conclude for vote of thanks. I invite IMA Thalssery Secretary Dr. Aravind Ambia.
Respected IAP State President Dr. Vijay Kumar, State Secretary Dr. Johnny Sebastian, IAP Thalssery President Dr. Mini Balakrishnan, IAP Thalssery President Dr. Sakriya, Dr. Santosh, senior members and members from IMA and IAP. Very good evening to all of you. First of all, I would like to express my heartfelt thanks to today's speakers, Dr. Shija and Dr. Nandakumar, for their excellent talks. And I'm sure each of you attending today's program would have definitely benefited and learned a lot of new things from this academic feast. Thank you, sir and madam. Secondly, I would like to thank the state leadership of IAP, Dr. Vijay Kumar and Dr. Johnny Sebastian, for coming up with this idea of conducting this COVID management workshop at a time when our state is seeing record number of cases daily, especially in with respect to the pediatric population being affected like never before. Thank you, sir. Especially thank you to Dr. Sakriya, who has been the man behind today's program. I know personally how hard he has worked to organize today's session. Thank you, Dr. Sakriya. Next, I would like to express my gratitude to Dr. Santosh and Dr. Mini Balakrishnan for their wishes and their continuing support. And I would also like to thank IAP CGP Chairman, Thalssery Chapter, Dr. Nadeem, for ensuring maximum participation from the CGP members. And finally, I would like to thank each and everyone who has attended today's program and contributed in making it a grand success. Thank you one and all, and good night.
Thank you.
Thank you. Just wind up. Good night.
Good night. Good night all.